it's multiple lesions. So multiple lesions, you are talking about, for example, metastasis or lymphoma, or in this case with omental, like have multiple peritoneal lesions. So you are talking, could be carcinomatosis, peritoneal carcinomatosis. So it can be a primary as mesothelioma or secondary metastasis from ovarian cancer, for example. So you are talking to try to limit the differential diagnosis, but finally you will say that it's differential diagnosis. For example, this case was mesothelioma. And for a single lesion, and it have hyper intense area in T2, and there is intense enhancement again in the post contrast, so very similar to the GIST, and it have this appearance. So you can think about GIST, or here can be neurogenic tumor like schwannoma. Not typical case, and not very common case, but it can be like this case. It is schwannoma. So the mesenteric pathology, multiple cases. Let's go to the cystic now. Cystic lesion. Very hyper intense in T2, as you see here. There is no nodules, no enhancement. You can see the link between this lesion and the pancreas. So what it could be? Yeah, pseudocyst. So try to, in this location, try to find any communication with the pancreas. If you find in the MRCP that it have communication, Taha, thank you, Rabab, Sumaya. So you are talking about pseudocyst. So that's good. Sure, that is differential with others. For example, this lesion, very high intense in T2 again. The post-contrast study, there is no nodules inside. And finally, it was something like lymphangioma. Just to know the differential diagnosis, you need in the exam to just have some list in your mind what it could be. Sure, that is not just one diagnosis, but just to know the criteria that help you to differentiate between the lesions. Again, let's take this scheme if it can help you. As we mentioned, the solid lesion, if it is cystic lesion, if it is multiloculated, think about lymphangioma. If there is any surgical site or operation, think about lymphocele. Sure, in case of pancreatitis or any link to the pancreas, pseudocyst will be the best. If there is link between bowel, so bowel duplication cyst, and it comes in random location, think about mesothelial cyst. There is much information in the literature. Many cases, to be honest, maybe just I try to make some overview quickly. I will just show you last slides about this very quickly, what it could be. So the common is common. The very common, as we mentioned, metastasis, lymphoma, or lymphadenopathy. After that, you will go to mention carcinoid, mesothelioma, sclerosing mesenteritis, fibromatosis, and you can, if it is single, think about desmoid, and primary peritoneal carcinomatosis. GIST, inflammatory pseudotumor, soft tissue sarcoma, desmoplastic round cell tumor. This is very rare, as he mentioned. This case was mucinous carcinomatosis, so peritoneal carcinomatosis, thickening in the peritoneum. Is easy one. This one was very typical in the exam with the scalloping of the liver. Again with mucinous material. So it is pseudomyxoma peritonei. They like to mention this in the adenocarcinoma of the appendix or any mucinous forming tumor. So the characteristic scalloping of the surface of the liver. Yeah, the colon and the ovary as well. So it can be from mucocele of the appendix. With thickened mesentery. All these are forms of pseudomyxoma peritonei. If you find a lesion with multilocular cystic pattern, we just mentioned it, you are going to think about lymphangioma. Lymphangioma, yes. And this is how it looks in the pathology. And this one, when you find it linked to a bowel, you are thinking about, to be honest, in this case, look like more linked to the pancreas, but they mention if here linked to the transverse colon, so you are going to mention that it is enteric duplication cyst. Again, another lesion in random location. So you are going to think about mesothelial cyst in random location. If you remember the scheme, I will just show you. Yes. There's one lesion, it's called peritoneal inclusion cyst or multilocular peritoneal inclusion cyst. Primary tumor, it is benign. It happen in the perimenopausal woman. They make it by exclusion. After you exclude everything, you can think about it. Multilocular lesion with enhancing septi, and it is related to the uterus. So, and it can extend to the upper abdomen. So you just think about something called peritoneal inclusion cyst. I hope that you enjoy this much information, and I hope that it cannot be bad. Now let's go for 10 minutes or maybe more 10 minutes, yeah, inshallah, for some cases with the rapid reporting mode. And try to be the first one who find the abnormality. I will try to help you. In the rapid reporting exam, it is part of the FRCR2B, and they have 30 slides. And if you are lucky, you couldn't miss more than 3. Maybe more or less than the exam will be normal. We are going just to train how it could be. They like in the rapid reporting to just mention the acute, like fracture, like inflammatory, something could be just like this. So mostly you are thinking about fracture or something acute. So what do you think? Where is the fracture? I will help you to think about the second. The second, yes. Where is it? Do you see it? It's not easy. So if you go to the basis of the metacarpals, and here you can see that there is abnormality here. So the second metacarpal base, there is a fracture. So which metatarsal here is affected? There is a fracture with cortical discontinuity in the third one. Not very easy, to be honest. This one, Sumaya, sorry, is a bit difficult cases. This one, if you want to diagnose it, you should see it at least one time in your life. So who will be the star today to diagnose it? It's not easy one. Yes, MacBook. Dislocation of what? You should mention to be more, to take the full mark. No, it's not here. Yeah, it's here. So there is a fracture of the metacarpal base. And the most important that you check something called the zigzag line, that this line should be above all this bases above this line. If you find any base down this line, probably there is dislocation and fracture in the base of the fifth. Thank you. Maybe, yeah. Everyone try to join and share his opinions. No fears. We are trying to train together. I'll try to focus in the pathology to help you. Yes, Rawab, thank you. So there is, you remember the exactly atlanto-axial subluxation, very critical in the exam. You will measure the distance, pre-dental distance, and you know that this distance is critical if it is widened as here. So this means that there is abnormal atlanto-axial subluxation. No is okay. We need something like acute. For the practice, you can talk about something, but here, no. You need something very obvious to talk about it. Very common in the exam to show you this one. So there is important to check the gas distribution of the bowel and to be in good distribution, and also to check if any narrowing. For example, here you can see the gas bubbles in good way. If you check this one also, it will be good. This one. But when you reach, yes, exactly above in this area, you will find that the descending colon have colitis. So there is colitis. Let's go to the pelvis, which is difficult in the exam. Thumb printing, yes, the last one with thumb printing. Thank you, Rabab. Everyone who try to share. This ring, and this is the ring, and this is the third ring. Then you are going to check some lines, like this line and this line, and here the same. And if you check this line, you will find something here. So there is left acetabular fracture. Very common in the exam. In any exam you will enter, you will find this appearance. You have your checklist. You are going to check multiple B's. One of them will be the first one, it will be the pneumothorax. So is it right or left pneumothorax? Exactly. This is the pleural line here. So this is the pneumothorax. And you can see clearly the pleural line is going here and here and here. And it's important to differentiate between pneumothorax and something called the axillary fold, or any fold in the skin. So here you cannot see any lung markings after this line. So this means that this is typical pneumothorax. This one is difficult because you are going to check with your checklist everything, and after you go until you go to the probably the calcaneus, you will find the fracture is here, which is not very easy one. Sorry, Sumaya, and sorry, Nirmeen, and everyone will have nightmares from this case. I will help you. Choose one of these three. It will have the pathology. So which one have the fracture? Exactly. Yes. So the fifth, the carbon. Thank you. Okay. This one is very easy. So the dislocation, you can see the dislocation in two views. Very easy one. Interphalangeal dislocation, proximal interphalangeal dislocation in child. Choose one of the metatarsal heads that it have pathology. So which one you will choose? Yes. Rabab and MacBook. We have 2 stars today in competition. Okay. When you go to the chest, you will find in your checklist something called the hyla. So this one is normal, the right pulmonary descending artery, and this is the abnormal. Because you have to be in angle, this angle should be preserved. So when you find it obliterated as here, you can see the contour is rounded here. So you are talking about left hilar mass. There is elephant, so you should have this elephant here and this elephant here. And there is one rounded halo here and one rounded halo here in this inferior orbital wall and in the inferior orbital. And if you check here, you will find that it's clearly the line here is easy. But here, there is ill definition and the lower aspect of this foramina exactly. So there is inferior orbital wall fracture with fluid, and this is the secondary sign that you find fluid. So search for this, and it will be the left inferior orbital wall fracture with fluid in maxillary antrum. This one, you shouldn't miss. Okay, so you should miss. So check for the osteochondral. If you find any lucency in the margin of the articular surface, so you are talking about osteochondral defect in the left lateral femoral condyle. Yes, Taha, thank you. I agree with you. Okay, you can leave this arrow because you point again to the pathology. Uh, exactly, yes. So what is the pathology here? When you find silhouetting with the diaphragm and there is double density behind the heart, so you are talking about left lower lobe collapse. So this is the typical of left lower lobe collapse. So exactly, Ivan, thank you. Left clavicular fracture. Okay, I want to delete this arrow, but okay. So it is lung pathology. So yes, I try to find the arrow to be here. Yeah, it is here. So this is the left midzonal lung opacity. Okay. The most common fractures here you are searching for supracondylar or radial head, but it is not supracondylar. It is not. Yes, it is in the exactly olecranial process, olecranial fracture. When you check for the shoulder, always check for any other associated lesions. So you will check for AC dislocation, glenohumeral dislocation, but don't forget the chest. So what is here? Pneumothorax, typical pneumothorax. Perfect. Sometimes the pathology, it can be acute, but easy one. So it is left renal stone. The ring of the orbit should be clearly defined. Yes, so there is distorted here, so this means that there is supraorbital fracture, left supraorbital fracture. I will try to clear this annotation, okay, to not disturb you. So try to remember the scaphoid leonate. What is this bone? Scaphoid leonate, and this one it will be traquitrum, okay, and this one trapezium, and you can see the trapezium there is leucine fracture, trapezoid capitate hamate. Sometimes the pathology can be very hidden in the hidden areas. One of them will be the apex of the lung. To compare the apex of lung on both sides, you will find that there is left lung nodule. Now you can see it clearly. Don't forget when you find this view to check for the elephant. So this is the elephant here. Any disruption in the elephant shape with this mouth, you will find the pathology. So here there is zygomatic arch fracture. Check for the lines and the tubes if you find any lines and the tube in the exam. And after that, check for any abnormal air. So if the air outside, it will be pneumoperitoneal. Not very easy, but it is. When you search in the cervical spine, search for any fractures, clavicle, then check for the ABCs of the lung. So here you can see this rounded area in the apex of lung, but this rounded area here, half of it is involved by mass. This could be what is called as right apical mass Pancoast tumor. Again in the lung, not very easy, but check it. That's the issue, that you should use the zooming to check if there is any upper lung nodule, especially in the hidden area. Yes, again mass. This view is more maybe easy one. When you find this, you are going to check for something called Bohler angle. Bohler angle, very helpful to detect the calcaneal fracture. So this one is calcaneal fracture, exactly. Again, scaphoid neonate, traquitram, BZ4 is okay. The trapezium here is fine. Trapezoid, capitate, hamate. So the pathology is in the capitate, exactly. So capitate fracture. Where is the fracture here? It is easy one. So Maya is okay. Inshallah, we can try to every time, inshallah, we can try to make some training. Yeah, the fracture is here. Very lucent, subtle one, but is present. Rabab, thank you. When you find this one, search carefully to the radius. If you don't find any fraction in the radius, search again until you find something. If you didn't find, search in the articular surface. You will find that there is fracture in the radius. It's not easy one, but it can be. Yes, MacBook. Yes, is here. I agree with you, Ivan. So there is Salter-Harris fracture. Yeah, I will draw for you. Okay. So until you draw the pathology, I will show you Bohler angle before we close. Let's say that it is the last case. Yes, this is the fracture here. Thank you. So Bohler angle, as you see, or the calcaneal angle. Normally it is between 20 and 40. If it is less than 20, then this is a calcaneal fracture. So this is the normal one. No, I think is more. Sorry, I will find you one more. This one, yeah. Yeah. So if it is less than 20, so this indicates that there is calcaneal fracture. So normally you draw one line here and one line touching these tubercles here. So one line touching this upper surface. And if this angle is less than 20, so you are going to mention that there is calcaneal fracture. I hope that you enjoy, and just if you find it like this, you will mention that it is calcaneal fracture. Okay, any more questions? I hope that you enjoy, and next inshallah session we can continue training and see you إن شاء الله. سلام عليكم.